So we have now we have time for the panel discussion, and we include Betsy Mellons joining us from Stanford as a professor there, and has been, as Vivian said, been leading this effort together with Vivian Vapor. And we have Mike Umbrello, who you all know from the sessions earlier, from the NIH, fellow mid-peds rheumatologist and SJIA-LD biologist. So why don't we start with questions? And I think we have a number of questions from the chat, but I wonder if we should start with any comments from the panel to start with. I might ping Fabrizio here. So Fabrizio has joined us from Italy, and I would. So I know we have. I don't know how much time we have you for, but I want to give you a little chance to reflect on the observations here with regard to systemic JA lung disease.
I joined right after Scott began his talk. I apologize to the entire group. I've never done this, but I had the press council. And these web meetings are a disaster. You can be in two places at the same day, and one was supposed to be Barcelona, and the other one was supposed to be DC, and it's been a nightmare today. Apologies. Really, I think the data that have been presented are fascinating. I think they point really to similarities. I'd like to ask Scott a question. If can I do that? Since you gave me the microphone, I'll take you to ask
Go for it.
Scott, could you comment on the last row of your last slide when you showed the tissue repair eosinophil-driven pathway, if I may say, if I got it right from your message? Can you comment on that for us?
Yes, this is so. You know, when you measure 1,300 different analytes, things pop up, and we did an analysis that focused specifically on cytokines and chemokines. You know, for semi-obvious reasons, we were looking in serum, and we're looking at an inflammatory disease. And you know, so what really stood out in the comparison of systemic JIP versus the systemic JA and MAS groups together were a few, you know, chemokines that, you know, so CCL11 was the one that was the most significant, the most differentially regulated, which is also known as eotaxin 1. You know, I think proteins get names, and the names that they get are often historical, but among the things that eotaxin 1 does is it's a chemotactic for eosinophils. But, you know, especially Betsy has done really just a lot of sleuthing to look into this. And, you know, you can find it in certainly in allergic diseases, but you can also find it as part of wound healing responses. And as I was saying at the end there, you know, a couple of these other chemokines that we saw, CCL7, CCL17, CCL25, have been sort of conspicuously associated with, you know, this Th2 paradigm. But as you know, the other nerds on this call will attest, there's a lot of overlap between what we mean by Th2 and what we mean by wound healing. And so I think it's a, you know, I think it's hard using our data set to say those chemokines are indicative of the drug hypersensitivity that Vivian's sort of better epidemiologic data point to, versus these are patients with known lung disease who are undergoing, you know, both inflammation and remodeling and wound repair at the same time. You know, I would be remiss if I said that these that we see, which are clearly enriched, are indicating one versus the other. So, you know, it's an open question. Does that clarify? No, Mike is shaking his head no.
It does, but it opens a lot of questions, and I understand. Grant, is there any chance you can get a look at the late phase of your lungs, of your mice with lung disease?
I can get what?
The lungs of your mice, late stages disease. If it is an acute process that you can kind of down modulate, essentially stopping giving CPG, if I got it right. Is there any chance you can look at the late stage of that lung disease?
Yeah, and so that's actually one of the things that we're doing now, is trying to understand sort of how that immune response in the lung changes during resolution, and then particularly then how it is then interrupted if instead of being allowed to resolve, there's sort of a continuous inflammation, which whether that's driven by underlying disease or by a DRESS-like process is clearly what's happening, right? Is that there is continuous inflammation that's perpetuating this pathology. And so I think one of my hypotheses is that there's sort of a failure to properly resolve that activation phenotype by alveolar macrophages that leads to their dysfunction. And that's one of the things we're trying to look at now in the mouse.
So, Greg, can I ask you two questions about your model? Because
can I ask just quickly? Are there any questions for Adriana before she leaves us? Any questions we should direct that way?
Adriana, this is Betsy. I have one question. So you talked about the changes in neutrophils and alveolar macrophages. Did you subphenotype any T cells in the analysis that you did?
I'm muted. I was muted. Sorry. Yes, we stained CD4 and CD8 double staining for these patients, as the 3 patients who had biopsies. But in comparison with SAB, it was very, very minor, the presence of T cells and also B cells in these lungs. We predominantly saw alveolar macrophages and also a lot of neutrophils.
Yeah.
But we do have the CD4, CD8 staining. Mm-hmm.
Yeah, the finding of ICAM5 in the interstitial areas of the lung, that's really quite striking that Gail found, is actually quite, first of all, it looks like those are fibroblasts that are making ICAM5. And second of all, it's highly correlated with monocyte and neutrophil infiltration in those biopsies. So
that's very interesting. Yeah.
Yeah.
Thank you.
Yep.
So I'm gonna have to drop off. So I'm gonna push Grant a little bit because I'm a jerk and he knows it. One is, how does what you're seeing compare to, there's this rich literature on inflammation and other things replacing alveolar macrophages in mice, at least, because so the alveolar macrophages derive from the yolk sac, but if you disturb the area, they get replaced by monocyte-derived alveolar macrophages. And eventually, if you look, and it takes like 6 months, the phenotype of those infiltrating alveolar macrophages eventually assumes, but in that process, it doesn't. And so I'm just wondering, like, how does what you're seeing compare to what's been published in, lethal irradiation or something? And then my second question, which I think is maybe the more important one, is SJIA is not new, MAS is not new, but lung disease appears to be. And so I think that's the hard part with some of the sort of, this is a failure to resolve in the lung, is what do you think about the epidemiology?
Well, that's a hard one, so we'll leave that one on for a second and talk about the first one, which is a little bit simpler. So I think that's a great question. And there's some, we've done an initial single cell experiment with the mice just in acute MAS. And the sort of the monomacrophage landscape in the lungs is very complex. And there is a big increase in sort of monocyte-derived inflammatory monocyte-like cells that we see, which is unsurprising. It aligns with what Lane Weaver and Ed have shown in the spleen elsewhere in that model. We also see emergence of a more differentiated pro-inflammatory macrophage within the lungs, separate from that expansion of sort of monocyte-derived cells. And so I think there's multiple things that are going on, which then, you're exactly right, I think then following those out over the course of months to understand sort of how those populations, are they transient? Do they sort of set up residence? Do they replace those embryonic derived macrophages in the lungs? And it's something, there's been a lot of work in mice, but there's very little bit about understanding how this actually happens in humans. Our pulmonary colleague, Chris Tao in Cincinnati, the other group that he collaborates most with is our bone marrow transplant group. And they've been following up kids who've gotten a bone marrow transplant for years afterwards and doing lavage. And so he has a data set in the freezer to be able to understand how do, after a bone marrow transplant, how do we start seeing replacement of lung macrophages by, graft-derived cells versus yolk sac-derived ones in actual, not furry little mice, but actual humans, which I think is particularly interesting as we start thinking about bone marrow transplant in some of these patients as well.
Grant, can I actually stop that discussion for a moment? Because I think what I wanted to understand is why now. That is, that I don't think the question of macrophage replacement in the lung is really important. It might be important, but it's not the critical thing for the moment.
Interesting.
The problem is we now have this incredible epidemiological association.
Yeah.
And it seems to me that we are dancing on a high wire here. That is, there are two possibilities here. One is that this is due to the therapies that we started to use much more abundantly, in which case we should change our practice. The other is that it's not the case that it's related. And this is some intercurrent trend along the lines of what amyloidosis was previously. An intercurrent trend we didn't understand, but was not related to the therapy per se.
Peter, can I make one comment?
Yes, Alexei.
So certainly this pruritic rash and peripheral eosinophilia in many patients with lung disease is actually quite striking. And we looked at our patients, and I can tell you that over the last 2 years, we have had 4 kids who developed very, very impressive peripheral eosinophilia with this pruritic rash at disease onset before. Well, they did get some Advil or whatever, but certainly not our typical DMARD. So they had this at the beginning of the disease. And when I think back, and certainly I saw similar patients, I don't know, 15, 20 years ago, but just a few. I have a feeling that I am seeing a little bit more of that eosinophilic expansion with pruritic rash at disease onset. And sort of because of some MAS features in some of those patients, we actually did a bone marrow. And I can tell you that what you see this sort of massive expansion of monomyelocytoid cell line at the extent of the lymphoid cell line. And I'm wondering whether in fact that eosinophilic expansion may be a part of the expansion of that particular cell line in general. And somehow that expansion sets up these kids to have allergic reactions to whatever. So I'm just wondering whether anybody else is seeing this peripheral eosinophilia with pruritic rash at disease onset more frequently than before.
There's a subset of patients in the autoinflammatory disease clinic that they call them the autoinflammatory urticariacs because they have extreme urticaria and allergic diathesis together with autoinflammation. Josh Milner was seeing them at the NIH originally. They're present in Dan Kastner's cohort. Daniela Schwartz is now starting to build a program attempting to investigate these. They seem to be a group that's distinct from systemic JIA, at least in the cohort that's being seen at the NIH. But there's clearly a group where there's overlap of atopy with or without eosinophilia and autoinflammation. It's not systemic JIA.
I have a couple comments on that. So that when we look at the large group of those that I have really specific information from at onset, and then there's the cohort that I have from onset all the way through to either drug reaction or lung disease. Among those cases, there are 80 with lung disease, and only one of those had eosinophilia at onset and a very unusual rash. So I think that phenotype exists. I don't really know what the denominator is. It wasn't anything I asked what I'm calling the institutional controls. However, I don't see that with very detailed clinical information as a descriptor of those that go on to develop what I was talking about in my remarks. That's 1 out of 80 with lung disease. And I have, I think, another 20 that don't have lung disease. I have over 100 cases, and 80 of them were lung disease. The ones that I showed you today are those that I have full data sets and those that had sequence data or DNA available to determine HLA. So Alexei, I agree that there could be some other presentation phenotype that seems to be different from the risk subset from what we're seeing.
And the other interesting feature about these kids is very, very high levels of IL-18.
Well, that's IL-18 you're talking during the lung disease, you're talking at onset in that.
At disease onset, right. So the last one that we had, the last patient, actually I just saw him yesterday, his level was 200, above 200,000 picograms per microliter.
So-
And disease onset with this, and he had this peripheral eosinophilia with very pruritic rash that responded, by the way, to a camera.
Yeah, I think it's a minor subset, and I have no doubt that that exists. You know, one thing, and I have great respect for you, Mike, in terms of looking at eosinophilia and calling that atopy. Eosinophilia and atopy are not synonyms. That there are very specific ways that you.
I'm not saying atopy. I'm just saying that this
No,
is also.
They coexist.
Not talking to you, Alexi.
They coexist in the subset of patients I'm describing, Vivian.
Okay, good. I just want to, make sure. So much like what Scott was saying, that this sort of, repair look when you see eotaxin, that eotaxin isn't allergy. I just want you to know that although these things go with allergy, you have to look at other parameters in order to make that that association. One of the things that's very difficult within these SJIA kids is that the rash, because some of it looks eczematous. So you think that this is atopic dermatitis. And so again, talking about all the confounding, that can be difficult to parse out. I still find it that the HLA finding that we were able to put together is striking, and that HLA findings tend to be very strong when there's drug hypersensitivity. It looks like this is a very strong HLA finding. Now, Lexi, that doesn't mean that the cases that you're talking about, initially, and I was up at my 5 a.m. to hear all of this, that happened, that there was a lung disease that happened without these drugs. Clearly, that's not drug related. So
certainly, the other thing, a couple of years ago, I was in China, and I personally examined a few kids with this lung disease who had never been exposed to any biologics. And again, the only thing I could see was some chest CT findings, and it looked to me like it was the same disease. I was planning a second trip to China specifically to look into that in more detail, but unfortunately, because of the political situation, I had to cancel that trip.
Yeah, no, I know that you were going to go back for that. But again, pulmonary alveolar proteinosis happens. The chest CT is not the same as a diagnosis of PAP. That when we look at these patterns, and I've had in-depth conversations with Paul Gillerman, who is a pediatric pulmonary radiology expert. I also have our pediatric pulmonary radiologists here and the adult radiologists in ILD. So these patterns don't tell you exactly what the pathology is. And I think we all have to very much keep that in mind. So although it's suggestive, there is no pathognomonic CT scan that will tell you what's going on histologically.
Mike, Betsy, go ahead.
I just wanted to say one thing.
Betsy, go ahead.
So, yeah. So I think that to me, there are two questions that need to be distinguished. One question in my mind is, can there be a situation in which drug hypersensitivity either is contributing, is an initiating factor? Is there a situation where drug hypersensitivity is contributing to lung disease? That's a different question than, is all lung disease drug hypersensitivity? And I think it's really important to separate those out. And it's important for the patients to separate those out. And overall, even, I'm just talking about two possibilities, two different questions. We all need to also remember, as we've been saying for this whole conference, that SJIA is not a disease, it's a syndrome, and that there are a range of children who are treated similarly, but that doesn't mean that they have the same disease, and that we're going to need a lot of numbers ultimately to identify these small subsets within SJIA who have a different biology, probably due to a different genetic substrate, but I said probably, I'm not sure that that's the case. Certainly this group with this haplotype is a subgroup of children, and as Vivian pointed out, we have now found children with a drug hypersensitivity that have not gone on to lung disease, some of those children for sure had the drug stopped because drug hypersensitivity was recognized, but we're way, it's way too early to say that that's why they didn't get lung disease. We just have some beginning numbers. And then just to sort of reiterate what Vivian said at the end, the data that she didn't show you is our data from Kawasaki disease, where we're seeing the same thing at the same, when I say the same thing, I have to be careful here because we're not talking about lung disease. We're just talking about drug hypersensitivity, and drug hypersensitivity in the setting of a different inflammatory disease with an inflammatory diathesis that is not SJIA, although we all know how close they can become, that we see the same HLA haplotype. So what that means to me is that we need to think a lot about what this HLA haplotype may be doing, but more importantly, we need to think about what's the consequence for children who are carrying that HLA haplotype and how we think about them. But I think, yeah, I'll stop there.
Yeah, I really fully agree with everything you just said there, and I think we have to think about, you're exactly right. I think lung disease, and not everybody with lung disease has this reaction, but I think there are definitely patients we need to think about what our treatment approach is, because we see kids where you feel like we're just pouring a biologic on there and it's not doing anything. And potentially it's causing harm through a drug reaction. And coming up with a different therapeutic approach is really challenging, of course. But we need to find a way to sort of break that cycle, because pouring more biologic on it is not doing the trick in the subset at least.
One of the things that I didn't have time to mention is that this very evil type of a drug hypersensitivity that is called DRESS, that has a fatality associated with it. The expectation is two things: that drug withdrawal is what you do in order to make the problem go away. However, when you withdraw the drug, the expectation is that the inflammation quixotically gets worse, certainly over the first several weeks. So if you have a drug that is actually should be useful in DRESS, but is causing DRESS, and now you remove that, and it's giving you the same kind of inflammation as MIS, you've now set up a potential powder keg to be aware of. It doesn't necessarily happen, but then it really confounds the problem of how do you address that. So if you want to look at, let's take this subset that look like they're having a DRESS reaction, particular 80% of them have this HLA type. And now you're going to have to separate what's SJIA and what's the drug reaction, which is very difficult. So SJIA, we have sort of a paradigm of how we approach the treatment. With DRESS, that review that I showed you had only 148 kids with DRESS as a full literature review. This is not a very common occurrence. And that in the DRESS literature, the primary treatment is always steroids. It is steroids as a pulse of steroids, as steroids that are given in significant amount, that the expectation is that the steroids are going to be needed for 1 to 5 months, even when the underlying condition is not a confounder like an autoinflammatory condition. So it requires particular anti-inflammatory. Now what happens is that not everybody responds to that. So that in hunting order, it looks like, and I'm not suggesting this is a therapy, but just to sort of think about it, one of the things that they're looking at is IVIG plus steroids in refractory DRESS that doesn't respond straight to steroids. And then, probably in perhaps in declining orders, since this T-cell mediator will be the calcineurin inhibitors, and the IVIG and calcineurin inhibitors we've used in SJIA before. And the third one that's sort of gaining interest is something that has now been approved in poly-JIA, are JAK inhibitors, and particularly tofacitinib, which is the JAK3 inhibitor, is really being looked at for allergic type inflammation. So without any real rubric for how it is that you choose what, there are possibilities. Each individual is very different. There are those that had a DRESS reaction within the first week. We would be foolish to think that SJIA is gone and that you can simply stop the drug and happy days are here again. It's far more complicated. You know, my most recent one was someone who developed noted lung disease 20 months into canakinumab. And so the question is, and the first CT wasn't until 2 years. And if you look at the canakinumab trials, like, is the SJIA gone? Is this all drug reaction? Well, we have no way really to know, but we have to keep those two avenues going as we approach therapy.
I guess I'm worried. I'm worried here. I'm worried here by the sort of the assumption that we know what's going on. It seems to me that we have seen cases of this disease in patients who've never seen biologics. The biologics are used all over the world, and this disease is not seen in many places where the same HLA subtypes are prevalent. And we've seen the disease continue, we've seen patients continue the therapy and the disease not get worse, very unlike DRESS. So I think that DRESS is an interesting hypothesis. Drug hypersensitivity is an interesting hypothesis. I think we do a disservice to the patients if we start to talk as if we know that this is the case, because I don't think we do. What is the thought there?
But Peter, how are you going to figure that out? If you don't give it the opportunity to be a drug hypersensitivity and think about it that way, and that although now it's anecdotal, which is the way the initial series started, there is increasing numbers of cases that have pivoted, and some where the lung disease has entirely resolved. In the initial cohort, there are none. There are those that, yes, it's stabilized. There are none that the CT scan became absolutely normal when somebody was.
We have some. We have at least one.
And then there are, okay. And then I know that there was, one in the cohort that 8 years later, everything resolved, but I'm talking, more promptly. So I think to not afford this as a possibility is also a disservice, given that we have something else to think about, other ways to treat it, and to simply discount it, I think does a disservice.
Viviana, can you,
I don't think that's what I said.
As an allergist, could you please comment on the fact that we are dealing with 3 biologics, 4 actually biologics. 2 are IgG1 antibodies. The other one has a completely different structure, and then we have rilonacept, again, a completely different structure. As far as
I can say with absolute clarity that is a very good question, and I don't know why.
So we have polysorbate, maybe.
So we have anakinra, which is a small molecule. We have 2 monoclonal antibodies, canakinumab and tocilizumab. And then we have this fusion protein. And that is absolutely a conundrum for Fabrizio. And I can tell with great clarity that I really don't have the answer. So there you go. Betsy, you might want to weigh in.
Yeah, I want to just respond again I just want to respond to Peter, because I think what I said was really an answer to your question. I think it's problematic to try to, to try to fully integrate lung disease and drug hypersensitivity. I don't think that's the way we want to go here. What we want to do is understand that there is a group of children that are being treated with these drugs, whether they have SJIA and probably whether they have other immune dysfunction disorders, where drug hypersensitivity will be a risk, a very difficult diagnosis to make unless you do a skin biopsy, et cetera. And even then it still can be difficult, but there are clues that there are things going on that are not the same as the underlying inflammatory disease. And so my take on this is not to try to put everything in one basket, but rather to say we need to have heightened sensitivity when we're using these drugs to the small group. We're talking about a small group, even though the HLA, this HLA haplotype is 30% in European descent Americans, only 6% in Italians. So that would predict that Fabrizio is not going to see as much of this drug hypersensitivity reaction. But in any case, my point is to say that staying alert to the possibility of a drug hypersensitivity reaction in people, not just children, people that are being treated with these drugs for underlying inflammatory disease, which in any review of drug hypersensitivity, there's a nice sentence that says that that underlying immune dysfunction, like in AIDS, like in transplant, are settings where drug hypersensitivity escalates to clinical, to real clinical. So that's
right.
I just stopped.
Betsy, I don't have any doubt that this is a legitimate hypothesis. It is an important hypothesis. It might be true, right? But I'm going to quote from your medRxiv paper. And what you say here in the abstract is that we observed severe delayed drug hypersensitivity reaction in a significant subset. That is not a caveated statement, right? That is a claim that you know what's going on. And I do not think that you do.
Okay.
And you have to be very careful about that kind of claim.
Okay.
I'm going to be very pointed about that. Fabrizio, I don't know if you want to dive in as well.
Is the registrar score a standardized score whereby when they fulfill that score, they have DRESS? Vivian?
That is what it was developed for. And they call it a diagnosis. I think we would call it a classification. They called a score of 6 to 9 definite when there's nothing that's really pathognomonic that tells you what it is. So I think that they look at this a little differently in the dermatology world. There is a bit of a diversity because there's drug-induced hypersensitivity syndrome, DIHS, which is sort of the Japanese counterpart of that. It seems more and more that that is emerging as the more persistent, more difficult dress reactions. I think that's what the dermatology world is sort of coming to. And that's the one where you have persistent reactivation of HHV6 and there's a much higher mortality rate. They're particular reactions to that. So I do take issue with this being called a diagnosis and it be called definite. I didn't make those terms. That's what the literature is using, and that's what the dermatology and those that are looking at that's what they're using. It doesn't really meet the standards that we tend to put in pediatric dermatology, but I didn't like this.
Fabrizio, do you want to dive in there? I know you were trying to get in there.
Yeah,
and Mike, I want to hear from you.
To get in there before, I think the word here should be caution. I think we have to be cautious. I think we have our antennas up as high as we can, particularly in big centers and in specialized people who take care of patients with SJIA. We have seen some patients. The disease is not as severe as. Only one patient has clubbing. 2 of them have been receiving emapalumab because of severe MAS. And their lung involvement in one patient is stabilized and is not progressing at all in only 4 months. And the second patient, unfortunately, comes from abroad and couldn't have a CT scan performed because they couldn't fly to Italy in the last few weeks. So this is an update on our side. Nevertheless, the word should be caution here. And I don't like strong statement one side nor the other side, in the sense that we don't understand what's going on. I'm sure we don't. There are a few simple rules in medicine, and DRESS is a very complicated syndrome, not a diagnosis. Vivian, I agree with you. And therefore, we should be very careful in making statement here. I think we are getting some translational research data, and I'm so sorry that I missed the first presentation. But the 2 I heard of, they really point to a dysregulated inflammatory response in several different directions. Pointing one of them clearly pointing, or 2 of them clearly pointing to interferon gamma being involved. So I think Grant was alluding to a treatment for this condition. I think we have a lot of evidence suggesting that there is one potential pathway. The JAKs are a potential pathway. We should investigate them. But I think we should be very cautious in the statement we make. particularly when we write these things down. Just make cautious statement. We are trying to understand something that was not present 15 years ago, or at least we don't think it was present. We didn't see it. Some of us were there, were here 15 years ago, and I don't remember seeing it, not hearing about it. I think the amyloidosis example is a perfect example of things that have changed over time without us understanding why. Why we had amyloidosis in UK and not in North America. I don't know. There's no genetic difference that could explain that. So I think we have to be very cautious. And remember, I just saw a comment from one of the parents saying, you know, think about those patients, the children who got their drugs taken away and passed away. So let's be very cautious here.
So I think you absolutely have to be very cautious, Fabrizio. And I think that there are two sides of the coin of caution. One side is to put the possibility of drug hypersensitivity aside and not pay attention to it. The other side is to take it seriously, work with that, and see if that affords some improvement. And that, you know, you're talking about, you know, cases here and there. What we've really gone to great lengths to do is to put together a full data set so that we can really look at this in the context of as many cases as we possibly can.
We should not look in as many cases as we can only to the drug allergy reaction hypothesis. We should look at all.
No, that's what I'm looking at. Drug allergic
as we did at the very first time when we started the first conference.
But when you have an anecdote after an anecdote, it makes it very difficult to draw conclusions.
There are situations in which you can only have anecdotes, particularly when you're talking.
So we are trying to best as possible with a rare disease to move away from anecdote. And
we are about at time. Mike, you've been trying to dive in there. Why don't you dive in quick and then.
I mean, from my perspective, this allele happens in 25% of the in-charge systemic JIA cohort. And when I match it with people who had the best genomics from this cohort that Vivian and Betsy have worked so hard to put together, 92% of the people who had the lung disease with genetic information had this, generated an odds ratio of almost 33 for predicting the lung disease compared to the GWAS cohort. Importantly, the odds ratio and p-values were almost the same with the healthy control population, and there was no relationship, no association whatsoever between this DR15 allele and systemic JIA between the GWAS cases and the GWAS controls. The hit there was DRB 1101 and 1104, you may remember. 1101 and 1104 are not active in this hypersensitivity lung disease versus systemic JIA cohort. The reason that this is the less powerful of the analyses, despite the fact that the numbers are much, much larger, is that there's the possibility that there was some of this occult hypersensitivity, or whatever you want to call it, Peter, this occult reactivity present in that big cohort. However, it's diluted by the fact that it's relatively rare compared to the bigger group of systemic JIA patients. When we took a step back and looked at people who didn't have genetic information to match with the cases, but rather just included everyone with the phenotype, we saw that the p-values got better because the trend continued with a larger size. The odds ratio changed ever so slightly, reducing about threefold, but it was because we introduced ancestral noise into our association testing. It's pretty clear that this is something that's unique to this group of patients compared to the bigger group of systemic JIA patients. The better group of controls was the group of drug tolerant controls that Vivian very meticulously inspected the charts to be certain that no feature even suggestive of a hypersensitivity or eosinophil driven process could be occurring. And in that analysis, there were very large odd ratios despite the very small number, relatively small number of controls. The association is very large, and to ignore the association because we don't like the words we're using to describe the thing that it's identifying as associated is the wrong approach. I don't care what we call it. There's an association and we need to figure out what it means.
So let's wrap up there. I think that was a fantastic way to end because it's a really cogent summary of the very compelling data that Vivian has presented today. And I think so I think that there's, I thank all the speakers. I think we'll have a lot of questions to answer from our parents, a lot of questions that we have to ask ourselves about how we use these drugs and what the implications are. So I think there'll be a lot of discussion going forward, a lot of work to be done, and contributions of the people and the speakers here today have been invaluable in understanding the most important question really in systemic JA biology at this time. So